Hi guys, I'm Dr. Neve Slevin and welcome to today's talk on dysphagia. Dysphagia is a common symptom that you may come across in real life or in the exam setting. The learning outcomes of today's talk include the definition of dysphagia, key questions in history taking, and a summary of different conditions which can cause dysphagia. So first of all, what is dysphagia? Well, it is defined as difficulty swallowing. And of course, like anything in medicine, if a patient presents with dysphagia, you need to take a full history. And broadly speaking, there are two key causes of dysphagia. That is a neuromuscular cause or a mechanical cause. And when we think of a neuromuscular cause, we consider things like achalasia. Mechanical causes include foreign bodies, gourd, or esophageal cancer. So when taking a full history, we need to ask the key questions that help us pinpoint what is the cause of dysphagia. So we want to know the onset. Was it acute or chronic? The progression. Is the patient's dysphagia getting worse on a daily basis? Character. Does the patient have a problem initiating swallowing? I.e., would they cough and splutter after taking a bite of something to eat? Timing. Is the dysphagia constantly there or does it come and go? For example, an esophageal ring may cause intermittent dysphagia, but esophageal cancer will cause constant dysphagia. And the key question to ask is about liquids and solids, as this helps differentiate is it a neuromuscular cause or a mechanical cause. So do not miss asking this question in a history taking. You want to know, has the patient difficulty swallowing solids? Have they difficulty swallowing liquids? Or have they difficulty swallowing both solids and liquids? So if it was a neuromuscular cause causing dysphagia, the patient would have difficulty swallowing both solids and liquids. However, with a mechanical cause such as esophageal cancer, the patient will have initially difficulty swallowing solids, and this may later develop into difficulty swallowing both solids and liquids. You also want to ask typical GI questions such as, have you ever noticed blood in your vomit? Have you been vomiting? And any change in bowel habit. It is also useful to show that you are thinking outside the box and that you recognize that not only GI pathology can cause dysphagia. So you could ask about cold hands or tight shiny skin, which shows your examiner you're thinking of neuromuscular causes like scleroderma. Or you could even ask about visual changes such as double vision that show that you're thinking of myasthenia gravis. If you are considering esophageal cancer, inquire about weight loss. On examination, you may find a lymph node in the left supraclavicular fossa, and this is strongly indicative of an upper GI malignancy. So what are the key conditions that can cause dysphagia? Well, the first one I will speak about is achalasia, and this is a condition where there is insufficient lower esophageal sphincter relaxation, and there is a lack of paracelsus in the esophagus. So there's very poor movement of food within the esophagus. This will cause dysphagia, which affects both solids and liquids, and there is a small risk of developing squamous cell carcinoma of the esophagus. If you do a barium swallow, you will see the classical sign of a bird's beak appearance. And this is a very common exam question. They'll describe a typical bird's beak appearance. They might even use the term bird's beak appearance, and they might ask you what would the diagnosis be. And this is achalasia. This is because the proximal esophagus is dilated, but the distal esophagus is very narrow. So that would give the typical bird beak appearance. It's also worth doing a chest x-ray in patients with dysphagia, as they have a high risk of aspiration pneumonia. And on chest x-ray, there's often a widened mediastinum if you have achalasia. You can also do a test that will show the resting pressure of the esophagus, and this is the gold standard test for diagnosing achalasia, and this will show a high resting pressure of the lower esophagus. The treatment of achalasia is with surgery. Medical treatment is a no-go basically. It has a very poor response rate and is only 10% effective. So medical treatment typically would use things that would dilate the esophagus, such as calcium channel blockers, but this is only 10% effective. So really the main treatment is surgery, and the gold standard treatment is surgical myotomy, and this is when the lower esophageal sphincter is weakened by cutting muscle fibers. And you can also use alternative treatments such as the injection of a toxin to decrease the sphincter tone, and this is not as effective and has a high rate of recurrence. Other key things to consider is GORD, which is a common condition and is due to lower esophageal sphincter dysfunction. And in GORD, the resting tone of the lower esophagus is decreased and there's reflux back into the esophagus. And this gives us heartburn, it gives a burning sensation, and it typically gets worse after meals or lying down. Another cause of dysphagia is esophageal candidiasis, and this will cause painful swallowing as well as dysphagia, and this is related to HIV and steroid usage. So in summary, dysphagia is a very common symptom. It is important to inquire about swallowing of solids and liquids. It is also important to check in with patients to ask what are they most concerned about, as this shows empathy and concern for your patients. So some patients may be very concerned about esophageal cancer, so you need to check in with the patients. Perhaps they have had a family history of esophageal cancer. So it is worth asking a patient what did they think it was. Achalasia is defined as failure of lower esophageal sphincter to relax fully and a failure of the normal paracelsus of the esophagus. Dysphagia can have mechanical and neuromuscular causes, so it is important to differentiate between the two. Thank you very much for listening. I hope you enjoyed this video, and don't forget to subscribe and hit the like button.